Yes, hello everyone. My name is Brant Fulmer. I'm one of the urology doctors at the Geisinger Health System located in Danville, Pennsylvania, although we have a number of other locations within Geisinger throughout the Wilkes-Barre Scranton region and also out in the western region towards State College. So we have urologists in many locations. I happen to be based mostly in the central region, although I am the chair of the Department of Urology, so I spend a lot of time in all of those locations. I am absolutely delighted to be here with you this evening to talk about something that's really near and dear to urologists, but also very important for men to have a good understanding of and their partners. Um, Benign prostatic hyperplasia or prostate enlargement and prostate health is really a critical part of what most men experience as they get older. And as our topic of our PA Health Talk tonight, it's going to be sort of an overview of benign prostatic hyperplasia, prostate symptoms, and also prostate health, which is intended for men and the people that love them. I think that one of the important things is toward the end of this broadcast, we will also do sort of a Q&A session. So if anybody has any questions, please feel free to put those in the chat, and there'll be some information about how to do that. This is important because I want to make sure that we're doing the best for all of you and giving you the information. This is intended to be an exchange of information, so questions are really welcomed. I do feel that slides can be challenging and it can be kind of boring, but I do feel like I want to give you some background and kind of show you some pictures of the prostate and some of the procedures that we do to give you an idea about kind of what's out there and what there is to help patients that have this kind of problem. So without further ado, let's go ahead and get started. And no talk would really be appropriate without some discussion of what the anatomy we're talking about. I used to title this slide, what the heck is the prostate? And the truth is that a lot of people really don't have a great idea, but most men, as you get older, just learn what the prostate is quickly, unfortunately. So the prostate is one of the male accessory sexual organs. It produces some of what's present in semen, about 20 to 30%, and also, fluids and secretions. Some of the things that come out of the prostate help during fertilization. Some of the things that the prostate produces, the prostate is very rich in zinc. So there is some theories that the prostate may help with keeping you from getting infections in the urinary tract. But anyway, around it, the prostate's an organ which, when you're younger and are trying to have babies and the like, you definitely, the prostate's a very useful gland. As you get older, I think most people would consider it to be more of a nuisance. However, this picture that I'm showing you here is really a picture of the anatomy. And as you can see, this structure up top is the bladder. In the middle of this is the urethra, or the tube that comes out to the tip of the penis. And then you can see the prostate. It kind of goes all the way around the urethra. This is just a cross section. But what it shows you is that the prostate sits around the urethra, and if it pinches it or pushes in on it or puts pressure on it, that can cause you to have some obstruction. The other thing to keep in mind is that downstream of the prostate, because the urine goes this direction, downstream of the prostate is something called the external sphincter, and that is the thing that voluntarily allows you to hold your urine. One of the problems is, as the prostate gets bigger, the sphincter doesn't work as well because it doesn't have to do much work. So I think that's one of the things that's kind of important to understand what the anatomy is. And you'll see some other pictures that are similar to this. So there's all kinds of definitions for what the expression BPH or benign prostatic hyperplasia means. Does it mean the symptoms? Does it mean the size of the prostate? These are all a bunch of things that we measure within urology. And I think there definitely is some controversy about what how you define what this exactly is. But what we do know for sure is that it causes men to have a lot of symptoms. And so what are the symptoms? This slide looks complicated, but it really isn't, because it's basically circles within circles, and it's intended to show, to kind of demonstrate that it would be really simple if it were just BPH. But unfortunately, there are a lot of other categories within the symptoms that relate to the prostate. So you have enlargement of the prostate, but not all people with enlargement, that's what this circle is, necessarily have obstruction. the people that are bothered by symptoms do not always have enlargement of the prostate. And so, that keeps me in business in trying to figure out who needs what in terms of treatment. But I do think that it's key to recognize that you can have some men that have very small prostates and pretty terrible symptoms, and you can have some men that have very large prostates and really don't have much symptoms at all. And this is explained by the fact that there's overlap here of all of these things, but there are some that exist without overlap. So it's not necessary to say that if you have, let's say, frequent urination and getting up at night, that automatically means it's the prostate, because truthfully, a lot of women have that too, and women don't have prostates. So I think this is a critical piece of what we're talking about. Now, this is a very complicated slide, and by no stretch of the imagination would I want any of you to become a cell biologist or a prostate growth specialist. But I do think it's kind of important to recognize that on the left side of this screen, what you see is the idea of the prostate as normal, because there's a balance between all these other things which aren't really that important for you to know anything about, other than the fact that there's kind of a balance. As men get older, it starts to shift to the right. And what happens is that the prostate gets larger and it becomes unbalanced. So you get more cells that are produced in the prostate, and the cells that are dying off are less. And that's sort of where the balance gets out of kilter, so the prostate grows significantly. The only other thing I would want you guys to see related to this particular slide is the fact that this is driven by androgen, specifically testosterone. And so that's a critical piece of this, is people will say, well, what causes BPH? Well, testosterone really causes BPH. But those are the things that make a difference. And you can have some men that are just more sensitive to the testosterone than others and develop bigger prostates. People also talk about, does that run in families? It often does. So patients will say, well, my dad had problems with his prostate when he was in his 50s. And so they start to have problems with their prostate roughly around the same time. And that's a very, very, very consistent finding that we see in patients and patient families. So let's talk a little bit. This is sort of the picture that I showed before of the cross section of the prostate. And it's a little bit of a weird picture, but really on the right side of this screen, you can see pretty much the normal prostate, kind of like the picture I showed you before that was blue and white of the prostate sitting around the urethra. And you can see on the left side of this screen, when the prostate grows significantly, you can see how it pushes into the middle, it pushes into the bladder. And it can also cause you to have some changes within the bladder. And that's what this is showing. This sort of lumpy, bumpy, or honeycomb appearance to the bladder is bands of muscle that are there that are stretching and pushing to try to get the urine past this giant prostate. So this is really just to show you kind of the normal circumstance and then the abnormal circumstance. And this is pretty far down the abnormal spectrum, but this is kind of what we do see often, unfortunately, when patients come to see us. So enough about anatomy. Let's talk about like who is affected. Well, I think when we talk about who's affected, we're really talking about sort of what we call epidemiology, or sort of the characteristics of people that are going to have problems with this. And so it's men, for obvious reasons, because the prostate exists. But also, we know that as people get older, it changes significantly. So in their 50s, as an example, you have 3 times the risk of having BPH as someone in their 40s. But when you get to be in your 70s, you have 8 times the risk. So the point is that as it goes up with age, the risk of having problems with BPH goes up in age. And then if you are looking specifically at people that have symptoms, if you have symptoms that are related to the prostate, we'll talk about those, you have about 3 times the risk as somebody that has only mild symptoms. And so that kind of makes sense. If you have a big prostate, you expect to have symptoms. And then the other thing is, we know that although it's not always true, as I mentioned, that large prostates cause obstruction, it's more common that they do. So patients with large prostates are much more common to have obstruction or this BPH phenomena than men that have smaller prostates. So this is a slide that's a little bit of an old slide, but I think it does sort of show what you're looking at. It shows the number of men in the United States that between 50 and 79 that have BPH. It's roughly about 5.6 million, and a lot of them are untreated. And so that's an important thing to remember. So it's a really significant problem. It's about the 4th most common disease process in men, which is kind of crazy when you think about all the things that are out there, like coronary artery disease and hypertension and everything else. BPH is extraordinarily common. There are just some other numbers here. I kind of like fast facts. I think it's kind of good to listen to. 50% of men at age 60 have BPH and symptoms. About 40% of men in their 70s have it in this other study that was done. And then another one, about 80% of men at age 80. And that's consistent with everything we've discussed, which is that as people get older, their prostate gets bigger and you tend to get symptoms. So one of the things that's important to remember is, yes, people will ask, is this just part of getting older? The answer is yes, but it doesn't have to be. You don't have to live with those symptoms. There's lots of ways that we can help with that. And that's really kind of what we're here to talk about tonight. As you might notice, some of these studies are very old because the truth is BPH has been present essentially from the beginning of time. So this is something that it doesn't really matter whether the study comes from 1950 or 2025. The results are essentially the same when it comes to enlargement of the prostate. So this is just another slide. I really don't like graphs and slides, to be honest with you, but this is another one that shows kind of what I was just explaining, and that is that the percentage of men on this left-hand column that have prostate BPH and symptoms is essentially increasing over time. So this is age 40 right here, and this is age 80 right here. So you can see if it's 10, 20, 30%, it's 80 to 90% by the time you get to age 80. So very common to have this problem, but not always an issue related to, not every man has it, but it's extremely common for this to be a problem. I think most older gentlemen in our audience can attest to that. So let's talk about the symptoms specifically, because that's really important. So for patients that have benign prostatic hyperplasia, they often will have nocturia, which is nighttime trips to the bathroom. They often will have a weak stream or potentially trouble starting the urinary stream. Some of them will have frequent urges for urinations. Guys will tell me, boy, I used to be able to hold my urine and when I went to the bathroom and now I'm on my way to the bathroom and I'm starting to pee. And that is a common thing from the prostate, and I'll talk about why in just a second. The other thing is the need to strain or the push to initiate urination. When you have a lot of blockage, I would like to tell you that this is a lot more complicated than plumbing, but it probably isn't, in the sense that the bladder is essentially the reservoir that holds urine, and the prostate sits around the drain. And so if your drain is clogged or blocked, several things happen. Number one, the pump stops working. The reservoir, the bladder, the pump stops working. And so over time, that can be what happens if we're not careful in taking care of patients with BPH. I would say that the other thing is when you feel like you haven't emptied your bladder completely, or you're going to the bathroom very quickly after you get up in the morning and you pee once and then you pee again in 20 or 30 minutes, then again in 20 or 30 minutes, and then kind of you normalize for the day. That's an indicator that's sort of telling you that the prostate is enlarged and causing some obstruction. You may be overcoming it throughout the course of the day, but overnight your brain is telling your bladder to hold the urine. So as the bladder gets kind of stretched, it doesn't squeeze as well. And so often in the morning, people have these multiple voids or multiple episodes of urination in order to get empty. Dribbling after urination is also a common circumstance that we see in men, and one of the ones that bothers them the most. They'll say, well, I'll stand there and I'll shake it off for a minute, and then I put I put myself back in my pants and it's draping out my underwear. So I think that is something we see in patients, and one of the reasons for that is, if you take a straw and you put your finger over the top of it and you lift it out of a glass of water, the water stays in it. So it's sort of a vacuum phenomenon, and that's part of what happens when you're blocked up above, is that occurs, and so you don't necessarily empty as well, and there's some urine left in what's called the urethra tube, and that will drip out at the end kind of on its own accord. There are some things you can do to help with that, but that's something that we definitely see. Again, this is a list of different kinds of symptoms based on sort of what the problem is. But just so we know, in case I use some of this terminology, urgency is the strong urge to have to go to the bathroom. Incomplete emptying is when you feel like you haven't emptied your bladder completely. Straining or slow stream is a low force of stream. And the important thing is about 2/3 of men that have lower urinary tract symptoms from BPH have it from more than one symptom. So it's not usually just one symptom, it's multiple symptoms. And when you really ask people this, they'll tell you, yeah, I'm going to the bathroom more often than I used to. The stream's not as strong. I'm getting up at night more often. And those things can really impact people's quality of life. And so it's one of the great joys that I have in my career to be able to help people get over this, get a good night's sleep, all the things that we would hope for folks if we get them treated for this problem. When we diagnose people, some people are kind of like, oh my goodness, is this going to be a terrible diagnosis? A lot of the information you get from people is really from the history. But these are some other tests that we can do. We can check the size of the prostate. We can look inside to see how much blockage is there. We can measure how well you're emptying your bladder by measuring how much is left after you pee. And some of you may have had this done in different settings in the hospital or in the clinic. We can also measure how quickly you flow and how that compares to other people that have issues like that. We can look at your urine to see if there's evidence of blood or other abnormalities. And finally, we can do something called a digital rectal exam, which can tell the size of the prostate, but it can also see if there are any prostate nodules or anything that's concerning for prostate cancer. And although we're not specifically talking about prostate cancer tonight, if people have questions about that, I'm more than happy to talk about that when we get to the chat segment. One of the things that's important is it's a very common problem, but if you look at the number of patients in millions that have this problem, there's only about 1.5 million people that come to the doctor to be seen for this problem. So this is a critical piece of, of information that we have, that some people are just living with these terrible issues. And so, as I mentioned again, and you'll hear me say this a couple of times probably, although it is a part of getting older, it's not something you necessarily have to live with if it's interfering with your quality of life. So let's talk about treatment options a little bit, because this is the sort of last part of the presentation that I have, which really talks about kind of what do you do for people that have prostate enlargement. And we're really going to put it into essentially two categories. We're going to put it into a medical therapy category, which is where we would give you medicine to impact the prostate or the function of the prostate. And then number two, we're going to talk about some surgical treatments. Now, we probably have 10 or 11 different surgical treatments. I'm going to talk to you about 4 of them or 5 of them that are all a little different. But the key is that with all of the surgical treatments that we do, pretty much, the idea is to fix the plumbing, to open the drain, to get the urine passing more freely through the area where the prostate was. So let's talk a little bit about something that people with a Y chromosome are very fond of doing, and that is not doing anything related to their health. Men are notoriously will ignore their health if they have a choice. And so one of the things you can do is sort of watchful waiting. And usually the way this is presented to me when I see patients is they'll say, well, what if I don't do anything? And so the answer is there's no reason why you have to rush to do anything unless you can't pee at all. There's no reason why you have to rush to do it. However, watchful waiting doesn't mean we're ignoring it. I'll see you in 20 years when you can't pee anymore, or I'll see you in 5 years when you can't pee anymore. The idea is that we kind of keep an eye on you. So we have you do things that will help with the symptoms, like decrease fluid intake, moderate alcohol and caffeine, which both can irritate the bladder and cause you to produce more urine and give you more symptoms. And also we can sometimes with people put them on a time schedule where we don't allow the bladder to get over full. So that symptoms sort of, will kind of settle out once you get somebody on a sort of a 2-hour avoiding schedule or something like that, rather than waiting 3 hours and being over full. So these are some of the things that you can do, but I think the key to it is this second thing here. And it doesn't imply the absence of any intervention, and it doesn't imply that we don't monitor what's going on, because that's a critical part of what we need to do to make sure that the horse isn't getting out of the barn. And what some patients will say is, well, I'll know if the symptoms get worse. Most of the time you will, but a lot of times they get worse slowly. And sometimes you accept the new symptoms without really recognizing, and this is just true normal human nature, to accept some of those symptoms as being the way it is without necessarily knowing that you're getting worse or potentially putting your bladder or kidneys or other organs at risk. And so getting plugged in with a urologist and having us talk to you and keep an eye on you is really a critical part of this if you're having problems with BPH. So first the evaluation, and then usually second, us being able to follow you if we determine that you do have BPH and symptoms. But just so you're aware, I'm a surgeon. I love to do operations on people that help them, but I'm not in the habit of wanting to operate on people that don't need it done. And so from my perspective, I think it's really important to let patients know that, I don't want you to have anything done that you don't need to have done. So we would only essentially look to do this if there were an indication to be doing it. Now, let's talk for a second about medical therapy, because this is something that many of you will recognize or hear. You'll have friends or maybe you yourselves will be on a medicine to help with BPH. And there's really two categories of medicines. One is alpha blockers, and that's this first two categories here. And they block alpha receptors in muscle. And where that muscle is generally is in the prostate, the neck of the bladder. So what happens is that it relaxes that muscle. So therefore, when you go to pass your urine, it reduces the resistance in the area of the prostate by relaxing that muscle. And it also will allow your bladder to sort of think that there's less resistance and therefore reduce its symptoms of frequent urination and things like that. Most of the time, these upper two medicines we don't use pretty much anymore. They were typically used for blood pressure and sometimes for prostate. We use these more selective ones, and the names you might hear is tamsulosin, the brand name of that is Flomax, alfuzosin, the brand name of that is uroxetrol, and silodosin, which is the brand name of that is Rapaflo. Interesting names for medicines that increase your urinary flow, so I think it's kind of interesting. And then there is another category of medicines called the 5-alpha reductase inhibitors. And what they do is they interfere with the testosterone piece. So what they do is they actually shrink the prostate. And there's two of those medicines, one of which is called finasteride and one is called dutasteride. So I'm going to take just an opportunity here for a second and talk about the patients that we might think would be best for this kind of therapy. And there are people that are starting to have bothersome symptoms. They have sort of a poor quality of life. I wrote here symptom score alone. There is a symptom score that we typically have people fill out, and sometimes that can help us to determine how bad your symptoms are. Also, you have to be committed to take the medicine. The medicine works if you take it every day. If you don't, it may not necessarily work that well. And specifically in the category of medicines which I mentioned before, which are the ones that shrink the prostate by interfering with testosterone, those medicines can prevent BPH from progressing or becoming worse. And in fact, those medicines have been shown to reduce the likelihood of having surgery and reduce the likelihood of not being able to pee from retention by about 50%. So that's pretty impressive numbers for any medicine. So I'm going to go back for a second. So the question is, you've probably heard the expression, there's no such thing as a free lunch. Well, the truth is that there's not. So these medicines do potentially have some side effects. And one of the side effects that the medicines can have is the ones that relax the muscle can cause folks to have something called retrograde ejaculation. And what that means is that when you ejaculate, you have an orgasm that's normal, but you don't see any semen come out. And that's because the semen's going back into the bladder. It's not harmful in any way. And the next time you pee, it'll be in your urine, but you won't necessarily see that. So, or know that it's happening, but that's kind of what happens. But that can be very unnerving. So we counsel patients carefully when we do that. The second medicine that shrinks the prostate because of interfering with testosterone really only interferes with testosterone in the prostate. However, there is a little bit of testosterone that's in other places. And so some men will say that it decreases their libido a little bit, which for some men is challenging, and can interfere with sexual functioning. Although I think that's a very, very uncommon side effect of that medicine, but it's something that you could potentially see. And so, again, these are really good medicines that work very well. The other thing to remember is they work much better together, both of them, as either one does individually. So just something to think about when we're talking about medicines. We have really good medicines to treat this. So if you're at the point that you're like, oh, I just saw Dr. Fulmer present surgery, I don't want any part of that. But there might be something for you in the medicine realm where you don't necessarily need to have a surgical intervention. So let's talk a little bit about something that tends to be near to dear. Having worked in central Pennsylvania for over 20 years, I know that this is something that's very important to folks to talk about, so I want to make sure I cover it. I wish that I had more information about it for you that's specific, but I think I can hit the high points. And that is, what about supplements? And this is just a picture of, 10 different kinds of supplements that are out there. Super beta prostate's a very common one that we see. There's something called prostate support, super beta prostate advanced, herbal prostate complex, salt palmetto with prostate and urinary health, and then beyond prostate, which I'm not entirely sure what that means, but I do think that these medicines are out there, and you will see these advertised all over the place, as well as in every health food store and also throughout the internet, on Facebook, and on all kinds of social media. So I think it's important to kind of keep in your mind, and a lot of them will say most urologists recommended, most commonly urologists recommended, supplement. And I think some urologists do recommend these, and I have a lot of patients that take supplements, and I don't have a problem with that. One of the problems with supplements, I'm going to try to show you with a slide I have here. So as a urologist, I have a little bit of a challenge with them for this reason. These are two different ingredients from two different supplement packages. And what they have in them, you can see there's a long list of things: saw palmetto, Pygium africanum. This just says prostate. I'm not really sure what that means, whether it's ground up prostate or what, or whose prostate it is. I'm assuming it's an animal prostate, but it's a little bit unclear as to this. It has magnesium in it, a bunch of things. And then you flip over here and you can see the milligrams. We'll just use saw palmetto as an example, 300 milligrams, and they want you to take 3 capsules, which would be 900 milligrams. On the left side, you have this other prostate supplement. This has 320 milligrams in it, as well as pollen and nettle and pumpkin oil and phospholipids and Pygium, which is over here. But in this case, in the Pygium, in this group, they're only having you take 2 tablets, and they're 320 milligrams. So in one case, you're taking 600 milligrams, and the other one, you're taking 900 milligrams, and this can be several times a day. So it's a little bit unclear sometimes, when you look at supplements, how to compare apples to apples or oranges to oranges. It's really hard to do. And so one of the challenges, what I tell people is, if you have somebody that you are, that has swearing by a supplement that they're taking, I don't have any objection to taking it. I'd make sure you know what's inside of it. But other than that, I don't think it's too much of a problem for people to take supplements. The other problem with supplements that I think is worth mentioning is you see this long list. It's a long list on the right and left-hand side of this screen. How do you know which one is working? So the only way to know which one is working to test things individually. And so I'm going to show you a little bit of that, but that's basically the issue with supplements. And so these supplement therapy is called phytotherapy because most of those things are derived from plants. It is big, big, big business, $80 million a year in general. About half of the people that have BPH take a supplement of some kind. And there are 2 of them, and you saw these specific ingredients in some of those formulas: the saw palmetto, which is a palm-based extract, and beta-cytosterol, which is another plant-based estrogen-like compound. So saw palmetto, again, there's a couple other names for it, but it is the most widely studied one because lots of people take it. It blocks testosterone, similar to the medicine that we talked about, which was the second group of medicines for the treatment of BPH. And I think when you look at studies and what placebo-controlled studies are, I think probably most people know this, but that's when they give you like the medicine and a sugar pill, and they don't tell you which one it is. So, and then they ask you, are your symptoms better? And so what they do is they look at the people that are getting the sugar pill and they look at the people that are getting the medicine, and they determine which one's doing better. And so for saw palmetto, most of the stuff that's out there says that you get about a 28% reduction in your symptoms. That's not insignificant. That's a lot. And you get about a 26% or a quarter increase in the rate of your flow out of the bladder. So that's pretty good. And that's why I don't really feel like patients shouldn't use these if they want to use them. I want to talk for a second about beta-cytosterol. That's the Pygium africanum you saw on that previous slide. And you also have a number of other things that comes from African prune plants, can come from stargrass, can come from pine flowers, from all kinds of different locations. And in this case, it's very interesting because although it has a slight estrogenic effect, which really is a female hormone, but it also has an anti-inflammatory effect. And what it does is, like a medicine like ibuprofen or another anti-inflammatory medicine, even like aspirin, that could be a significant difference in your quality of life because it's reducing inflammation and swelling in the area of the prostate. Now, in the placebo-controlled studies, like I mentioned before, this one actually performs a little bit better. People are noticing about a 50% reduction in their symptoms and about almost a 70% increase in the rate of their flow. So what I tell people is that certainly these medicines may have a place if you want to take them. I think the problem is that you probably want to stick to one medicine, and you probably want to stick to one brand, so that you're getting the same amount each time, so you can know if you make a change whether it makes a difference or not. But I think sometimes we see people that will switch brands, that will buy one every, kind of buy a different one every month, and then it's really hard to know if it's working because you're not sort of getting the same doses as we mentioned before. So that's a big explanation about supplements, but something that I think is really important to talk about, because although we don't think of it as commonly as medical therapy, it is something that a lot of our patients take. And certainly within many of, so for instance, within the Mennonite community, supplements are very, very, very common, as they are in just in general in our sort of geographic area. So this is an important thing for doctors to know about. And I have no problem. I always tell my patients, if it is working, I'm most concerned about your symptoms and that your bladder's getting empty. And the reasons why it's working, I'm less concerned about, as long as it's not harmful. And in general, these are not. So I want to talk a little bit about surgical options, because what happens when you're not emptying your bladder anymore, or what happens when the symptoms become so severe that medicines or other things cannot help you. And I think in that situation, often we start talking about surgeries for the prostate. Now, if we think about, what are the reasons one might have surgery? Well, one reason is what we call urinary retention, or the inability to pee, right? That's an absolute, if you will, indication to have a surgery done. A second possibility is if for some reason you're having swelling of the kidneys because you're not emptying the bladder completely. You're still able to pee, but you're developing high pressures. It's a system where the kidneys are connected by the plumbing to the bladder. The bladder has a high pressure that gets transmitted to the kidneys, and you get problems with your kidneys potentially long-term because of the fact that the pressure is sent that direction. So that's something that we think about. And we look at that by looking at things like ultrasounds of the kidneys and kidney function and other things like that, as well as how well you're emptying your bladder, which is a critical piece of this. The other absolute indication, stones in the bladder, I think are probably what we call a relative indication. Most of the time, if you're developing stones inside the bladder, it's because your bladder is not emptying completely, and that's a reason to have a procedure done. And then the other thing, there's two more. One has to do with urinary tract infections. So people that are getting multiple recurrent urinary tract infections because they're not emptying their bladder completely, and we determine that's the reason why they're having infections, those people are often people that would benefit from having a surgery done to fix the problem. And then finally, the other group of patients is those patients that have bleeding from the prostate. With the fact that we have so many patients now that take anticoagulation for different reasons, AFib or a blood clot in the leg or something like that, unfortunately, the prostate has a lot of blood vessels that sit on top of it, and they have water flowing over them with urine all the time. And often when you're, I have guys that'll tell me I bounce around on my riding mower and I come in and I pee blood, and they don't have anything wrong with them except that they have big prostate blood vessels, and they have some measure of anticoagulation, so they're having some bleeding that comes from that. Usually, as you might imagine, when somebody has bleeding in the urine, they come immediately to see the doctor, and that's a good thing because it can be other things other than the prostate. But that is an indication if people have that and it's happening over and over and over again, that's something that makes you want to think about doing surgery for people. So let's talk a little bit about surgical options. Now, this is another one of those charts that I don't love, but it does show you this very, very extensive group of treatments that we have for people that have prostate enlargement. And I think the one important thing, you don't have to remember anything on here except for this one piece of information. And that is that the treatment that we generally will recommend for you and the treatments we will discuss for you have to do with the size of the prostate. For people that have very, very big prostates, there are certain treatments that are better than others. For patients that have smaller prostates, there are certain treatments that are better than others. They're better on the basis of both side effects potentially and also on how well they work. So someone has a giant prostate, you won't want to do a procedure that doesn't open the channel up. The other thing that I tell patients is you want to kind of think about the prostate as being like an apple. that sits around the urethra, and many of these procedures I'm going to talk to you about are sort of like coring the apple. We do it through the penis. These are what are called transurethral procedures typically. We do them through the penis, and the nice thing about that is that there's no incisions or anything on the outside. And just in case anybody is like shaking in their boots here just thinking about it, we do use anesthesia for these things. So you're asleep when these procedures are done, and you wake up and the procedure's already been completed. And really what this slide is showing you is just that depending on the size of the prostate, the offerings are different. And I think that's something that your urologist would discuss with you when you decide that you want to have something done, or when you're thinking about, the symptoms starting to get bad enough that you want something done. We're going to talk about basically 4 treatments. So I have really 4 slides, I think, and then we're going to open it up to questions. So one of the things that we talk about that's a popular recent treatment is something called Rezum, R-E-Z-U-M. And it has a very, very long name, which is radio frequency induced thermotherapy with steam. But it basically what it is, it's a needle that is injected into the prostate. Obviously, patients are asleep for this typically. A needle injected into the prostate. And what it does is this tissue, this hyperplastic tissue that's squeezing in the middle, by injecting the steam, which you're seeing right here, into the prostate, it allows that area to shrink down. And you do it on both sides of the prostate all at one time. And then over a period of generally 3 months afterwards, that tissue will shrink back and you'll get much better flow. The advantage to this is it really is a pretty minimally invasive procedure. Most people don't have a lot of discomfort after it. Most people do very well in terms of symptoms. The catch to this is you can't do it for really big prostates. And so if an average prostate is, if an average prostate with enlargement is 40 to 70 grams or 80 grams, you're not going to want to do this for somebody that's over the 80 grams. And many people have big prostates. So Rezum isn't for everyone, but it is a very good treatment for people that, either are tired of taking medicine and want to get off the medicines and still want to get the symptom relief, or potentially those people who have failed medicine and want to try something else in order to try to get them peeing a little bit better. Let's talk about TURP, or what people used to call and still call, the old-fashioned Roto-Rooter procedure. And almost everybody knows somebody that had this done. There's some horror story related to it, sometimes not, depending on how, depending on what the circumstances are surrounding it. But essentially what you're looking at here is a view, and you're seeing here. So if you think about that urethra we looked at the picture of before, that's here, and this is the prostate pushing in on both sides. And what this is called an electrocautery loop. And what you do with an electrocautery loop is you take it and you essentially chip out, patients will say scrape out or carve out pieces of the prostate. Here you can see once they've opened this channel up on this side, you can see that now it's open over here. So the urine should flow nicely through there. And then finally, when everything heals, instead of looking like this, it looks like the lower right-hand corner, which is an open channel that you can pee through. And downstream of this, which we're not showing you in these pictures, but downstream, you can actually see where the urinary sphincter is, and we don't do anything to the urinary sphincter, so you still have good control of your urination. So that's a TURP, which stands for transurethral resection of the prostate. And it is probably the procedure we've been doing for the longest time, over 100 years. And it still works very well for the right person with the right size prostate and the right set of circumstances. It's still a good procedure, but because it's not for absolutely everyone, there's a few other things that we have in our armamentarium, and I'm just going to show you a couple more. We also have something called laser vaporization. So the idea of using a laser is similar to the picture I showed you of the transurethral resection, where you're going in and coring the apple, if you will, that is the prostate. We call it a green light laser because it's a bright green light in the operating room. But basically what you do is you go inside. This is that same picture of the urethra with the prostate on both sides. And this is the laser. And the laser fires out of the side and vaporizes the tissue. And so you can see it here through the scope that we use. It comes out on the side, vaporizes the tissue. And down at the very bottom below here, you can see the pre-pictures immediately in the operating room where you vaporize the tissue on both sides. And then finally, 3 months after it heals inside, stays open like that and is nice. And so I thank Dr. High for that picture. But that's basically the way that green light photoselective vaporization works. The advantage to green light laser is that it doesn't have as much bleeding. And so for patients that are taking, let's say, blood thinners and things like that, although we would stop them for surgery, we can restart them very quickly afterwards because the laser causes less bleeding. The disadvantage to the laser is if you have a very large prostate, it takes a long time to do it. And then also because it is a burn that's healing inside rather than a cut, it does take a little longer to heal, and you can have a little more irritation when you're peeing while that healing process is occurring. But generally speaking, it's a very good treatment, and we do a lot of green light lasers at Geisinger. I want to talk about one of the newer treatments, which is called robotic aquablation or water jet ablation. And basically, if you think about instead of using that laser that vaporizes or that resection loop that cuts the tissue, what this basically does is this goes ahead and takes a water jet that goes back and forth. And we do it under guidance with an ultrasound, which is what you see on the left-hand side. And this is essentially the prostate kind of cut longwise. And you can see this water jet that goes through here, and it goes back and it treats all of this area within the prostate that's within these green bars. And so the nice thing about it, or green dots, the nice thing about it is this particular procedure, you do it with ultrasound, so you can guide it very carefully. It's technically called a robotic procedure because it moves on a course that you plan for it. So kind of like your robotic vacuum or lawnmower might go around and do that. This is a similar thing. It goes through only the area you told it to, and there's a lot of safety mechanisms built in, so it can't do anything it's not supposed to. The advantage to this procedure is it's very precise, which is nice. Disadvantage is you have more bleeding because you're using less heat energy. So there is a little bit more blood in the urine afterwards, but this is a very good treatment for many men. For very, very, very large prostates, it's probably not as good of a treatment because it only penetrates so deep into the prostate. So I told you that a laser, for example, takes a long time to do because you're taking multiple layers. Here you're really only taking one layer. Some people will do a second pass or a third pass with the water jet and even move it a little bit. So sometimes we can do bigger prostates, but for people with really big prostates, there's a better option, which I'm going to show you now. So the last thing is holmium laser enucleation of the prostate, or HOLEP, H-O-L-E-P. And basically, if you think about the other things that I've told you as being like coring an apple, this is like peeling an orange from the inside. And so what you can see in these pictures is you can see, if you think about this being the orange with the outside of what we call the capsule of the prostate being the peel, what this is you go inside and you take all of this tissue on both sides and you basically shell it out inside and you push it into the bladder. We then have another instrument that takes it out of the bladder. But the advantage to this particular procedure is it's kind of size independent. So it doesn't really matter what size of the prostate it is or what the anatomy of the prostate looks like. You can kind of do it on everyone. So again, no such thing as a free lunch. Well, the challenge with this procedure is because you take a really big piece of prostate tissue, it takes a little bit longer for your urinary control to get back afterwards. And so you might have some urinary leakage early on when the catheter first comes out. So it brings me to, and this is the end of the slides that I have, but I wanted to sort of mention to you essentially the side effects that people have that are related to prostate treatments. And so the things we worry the most about are sort of the immediate post-op stuff like bleeding, blood in the urine and things like that. And I think I talked about which ones reduce that. I think retrograde ejaculation, which we talked about with the medicines, is something that's important for us to talk about related to the treatments as well, because most of these treatments will result for the same reason, because you're kind of opening this area and reducing resistance in the prostate. Most of these will result in patients having a high risk of retrograde ejaculation. Things like this holmium enucleation or a transurethral resection of the prostate and green light all have very high risks of retrograde ejaculation. I think for the Rezum treatment that we mentioned earlier and also for the aquablation, the numbers are lower, but even for aquablation, it's 50%. So it's a little bit of a coin flip as to whether that's going to work afterwards. We do some things to try to help with that, but that's an important piece. So if you think about it, what helps you for the ejaculation to come forward is to leave some tissue in there. But if you leave a lot of tissue in there, then you potentially won't be able to go to the bathroom. So you understand that, and it won't work as well as a procedure. So it's sort of a balance between taking too much, too little, and a lot of times that's what we see in men, is if they have good ejaculation, it's because there's a little tissue left behind and they're still able to pee and their symptoms are a lot better. The other question that comes up about prostate procedures is, how long do they last? Well, largely that depends on how much of the prostate you remove, because the prostate you don't remove the whole prostate in almost any situation. So you're going to be removing big pieces of the prostate, but there's still going to be parts of the prostate that are still there. And those parts of the prostate can cause you to have recurrence of symptoms. Now, when does that happen? Well, I generally tell people somewhere around 5 to 7 years for the procedures like green light laser or transurethral resection. I tend to extend that out to 7 to 10 years for homeoenucleation of the prostate, because as you can see in this picture right here, you're removing more tissue. And then finally, for things like Rezum has very specific data, and that is that the likelihood of needing retreatment at 5 years in the published data is about 20%. So for patients that have the steam treatment, for example, about 20% of them need to have another treatment, whether it's another Rezum treatment or whether it's something else done within the first 5 years. And so that's just, or at the first 5 years. So that lasts for less, as you might expect, if you're not removing as much tissue. So I think for now, I'm going to stop and see if anybody has any questions or anybody wants to ask any questions specifically. And they don't have to necessarily include questions about prostate enlargement, but I certainly want to help anybody with any questions they have regarding men's health, BPH, prostate health, that sort of thing. But I really appreciate everybody's time and attention.
Okay, so Dr. Fulmer, we do have questions
Great.
in the Q&A.
Great.
So the first one is, does having BPH make me at higher risk for prostate cancer?
Yes, the answer to that is a little bit of a question mark. There's some controversy that surrounds that, but I'm going to answer the question, which is, the answer is it does not make you at higher risk for prostate cancer. But the problem is, in the same way that I showed you that as you get older, your prostate gets larger and your symptoms of BPH get greater, your risk of prostate cancer goes up as you get older as well. Prostate cancer is generally independent of benign prostatic hyperplasia, which is why you call the one benign and you call the other one cancer. But it is absolutely true that you can have patients that have a lot of benign enlargement of the prostate that, in fact, will have prostate cancer, because the way prostate cancer works, and this is a scary statistic, but one that I want to give a qualifier for, it's about 10% incidence of prostate cancer past age 60, 70, depending on which study you look at. So what that means is, just in layman's terms, what that means is, if you're 70, somewhere in your prostate, there might be a small amount of prostate cancer. Now, that's not likely ever to hurt you. And you'll hear many people say you're more likely to die with prostate cancer than of prostate cancer. And that's where that particular statistic comes from, or that's where that saying comes from, because it's very common if people die for other reasons and you look at their prostate, which doesn't happen very often, but there have been studies done where they've done that, they see that the having some small amount of prostate cancer is very common. And that's one of the reasons why, as men get older, for example, when they get to be about 75, we tell people to stop checking PSA, because you might be chasing, be wild goose chasing something that would never hurt you. And the same thing is true below a certain age. If you're below 40 or 50, unless you have a family history, we don't recommend you being screened for prostate cancer, because your likelihood of having it is incredibly low based on age. So, long answer to your question, but I think that the important thing to remember is, no, one does not predispose to the other. But they are both more common with age. So it is, however, very important for us to rule out whether or not you have prostate cancer before we potentially treat you for your BPH, because you might choose a different treatment if you knew that there was a prostate cancer there. So often we will do an investigation like doing a blood test to look for prostate cancer, or an ultrasound, or sometimes even an MRI of the prostate, or very rarely a biopsy of the prostate, in order to figure out what your risk factors are prior to doing a procedure for BPH. What else can I do?
Excellent. So another one, there's kind of a 3 or 4 part one here. Are any of the treatments outpatient, or do you need to stay in the hospital? The second part is, will I need a catheter? And then how soon can I return to normal activities?
Yeah, excellent questions. All 3 questions are excellent. And part of our normal sort of education for patients when we talk about what procedure we're going to do. The procedure that's done as an outpatient typically is the Rezum treatment. And I'll tell you why the other ones aren't done that way. There's a few of them, like the green light laser, you could probably do as an outpatient, but there are some reasons that we don't. We're sort of unique at Geisinger because a lot of our patients come from long distances. So I worry a little bit about sending people home if they're coming from a very long distance. I don't want you to have you run into trouble at home. But so a lot of those people we will keep overnight. But Rezum is an outpatient treatment. We do, after the Rezum treatment, put a catheter in for a couple of days in order to, and it's usually a small catheter, but we put it in for a couple of days in order to make sure that the swelling of the prostate doesn't give people challenges with in the first day or two with passing their urine. But typically we have them take the catheter out at home, and most of them do extremely well, about 48 to 72 hours, something like that, after treatment. For the other procedures that we talked about, I generally, for the reasons I mentioned a little bit ago, will keep people overnight in the hospital. So you do a catheter put in at the end of the procedure. So they're 1 night overnight stays. So that's what we call surgical overnight recovery. So it's basically a 23-hour stay. So you get your surgery done, let's say at noontime, and you go home the next morning at 8 or 9 in the morning. So you're not really here a whole night. You're here over the night, but you're not here a whole 24 hours is what I meant. And so we will do that often with patients. And with a lot of patients, depending on the individual circumstances, we usually will send people home with a catheter for a couple of days. For the homeoenucleations of the prostate, we will send them home typically, for 48 hours with a catheter, and then have them come back and get the catheter taken out. For some of the other procedures, we'll have it in for slightly longer. Some of it has to do with kind of making sure that we have the right people in clinic and other things to take the catheters out, and making sure we can get you appointments to get the catheters taken out. I generally don't like patients taking their catheters out at home. And the reason for that is because when you come to our clinic, we do something called a provocative voiding trial, which isn't as good as it sounds. But what that means is we put a little bit of fluid into your bladder and we take the catheter out. And so you can pee. And a lot of guys that have had an experience before with a catheter are like, oh my goodness, I don't want a catheter under any set of circumstances. When you have a very large prostate, having a catheter can be very uncomfortable. But remember that after we do the procedure, the catheter is annoying, but it's not nearly as bothersome as when you have a big prostate sitting there, because we've removed that tissue. So as part of the healing process, we do that. We keep people overnight in the hospital because we like to do something called CBI, or continuous bladder irrigation. And the idea is that we can run some fluid through and make sure no blood clots form in the bladder. Usually by the morning after surgery, there's no blood clots and the urine's pretty clear. And then we just turn that fluid off and send people home. So in answer to the question, the one that we generally do as an outpatient is the Rezum treatment. And the others, you generally will stay 1 night overnight in the hospital afterwards. And that's really has somewhat to do with our population and where people live and that sort of thing. Because I really don't love people going to the emergency room. I hate to go there myself. And if I can avoid it, I want my patients to avoid that as well. We have within urology a really fantastic urgent appointment clinic in Danville. So for patients that have problems with catheters or things like that, we can get you in to be seen, very quickly, same day in the office in Danville. But again, I'd rather you not have the problem. And so we found that just after doing this, I've been doing this about 24 years. In doing that over that period of time, I found that it's just better to keep people overnight if I feel like you're going to run into trouble. So again, long answer to your short question, but important questions to ask about the postoperative recovery. The last part of your question had to do with when can I go back to normal activity? Well, the answer is you can drive immediately. You can drive immediately. That's a normal activity for a lot of people. I would say I tell people to avoid vigorous activity, things like bike riding, hiking, anything where they're doing a lot of straining, lifting heavy things, splitting wood, that kind of stuff is something that I generally have people not do that for about a week to 2 weeks after surgery because there's small blood vessels that seal during the procedure and seal immediately after the procedure. But if you put too much pressure in that area, you can get some of those bleeding and it just makes your recovery a little bit longer. But generally speaking, you can go back to pretty much whatever activity you want. Some men will ask, when can I resume sexual activity? Anytime is fine with that. You probably won't feel like it early on. Just because that area is healing, but there's no harm in that if that's something that that you decide that you want to do. The other question that comes up is return to work. So let me just mention that because, most people can go back to work in, usually a relatively short period of time. I will sometimes, obviously, while the catheter's in, most people don't want to work, but there's a lot of flexibility to that. So, you can, if you need to get back to work, you can get back to work relatively soon, like within a week. If you need to be off longer than that because of the kind of work that you do, then that's something that we generally can accommodate as well.
Okay. And then how often should I follow up after treatment?
Yes, generally we bring people in about 6 weeks after treatment, and that's in order to really see how you're doing, in terms of passing your urine and also to reassure you that the healing process is still happening. Then I generally will have people come back at another 6 weeks, which is a total of 3 months from the time of surgery. And then honestly, as long as you're doing okay and you don't have any other problems that you're concerned about, you don't necessarily have to follow up with us. We discharge a lot of patients from clinic at that point if they don't have other issues that we're dealing with.
Is there anything else that can cause me to need to pee multiple times at night, or is it likely my prostate?
Yeah, that's a really excellent question. And so the answer is in that kind of first 1 or 2 slides that I showed you, there are definitely some other reasons why this can happen. I think it's one of those things that, if it's a prostate enlargement is extremely common. So it's one of the more common reasons. So I would say that most of the time there's some component of that. But the bladder is the bladder and the urethra and the tube that comes out from the bladder are very complex organs that have a neurologic effect. If you've had a stroke or you've had a problem with something like MS or something like that, that can also be super challenging for people. And they can cause you to have symptoms. And the other thing that can do it is just drinking too many fluids. You can have people that are drinking lots and lots of fluids right up until bedtime. And for a fact that fluid's going to come out at night. So you can get up at night because of that kind of thing. And it doesn't only have to do with the prostate. Usually the prostate is a component in older men, but it's not the only thing. And that's one of the reasons as a urologist, that's important to me because I don't want you to be treated for something. It could be that if you came to me and gave me your symptoms, I would say, let's try one of the medicines. And if that makes you better, that's going to be something that we're going to say that's probably related to your prostate. After we measure, make sure you empty completely and that kind of thing. But in answer to the question, yes, there can be other reasons. And that's kind of what's important about following up and seeing somebody to kind of address these things. We have a lot of our primary care doctors that appropriately give people medicine for the prostate when they think that that's what it is. And our primary care doctors are excellent. And it's good for them to try patients on that. So a lot of times when patients come to see me, they've already tried medicine and it's not gotten them better. The other thing to remember about nighttime urination is there are some things that happen to the body at night, including laying down flat, where you get some equalization of fluid, they call it, or fluid that you might see in your legs at other times of the day that move back toward the heart and get filtered out through the kidneys, so you produce more urine at night. And then there's some hormonal changes as well that occur at night that can sometimes cause you to pee more at night. So BPH and prostate enlargement isn't the only reason, but it's the most common reason.
Okay, and you kind of touched on one of these about when to see a urologist and when should I just go to my regular doctor?
Yeah, that's an excellent
question. Kind of touched
question.
on that.
And I always encourage people, always talk to your regular doctor about it, because they will often say to you, listen, let's start, let's try you on a medicine or something like that to see if we can get your symptoms to be better. I think that that what I will tell people is, if you try a medicine, it doesn't work, that's definitely the time to see the urologist. Some people don't necessarily, because your family doctor isn't necessarily, your primary care doctor is not necessarily going to test all the things that we do. So I think if your symptoms are pretty severe, or if you feel like you're not emptying your bladder completely, that's often a reason to see the urologist, as opposed to just seeing the primary care doctor. But I encourage everybody to talk to their primary care doctors first. We have such a fantastic group of people that they definitely know when to send you. And they have some guidelines as well about when they send you to urology. But certainly, we live in a world now where you don't necessarily need a referral. So, some people will come to us without seeing their primary care doctor. But, that's something that I always recommend to people first off.
Okay. And then kind of tagging onto that, when should I have my prostate checked? And do I need to go to a urologist?
Yeah, and in terms of the prostate check, what I would say about that is it depends on whether you're talking about prostate enlargement or whether you're talking about something like prostate cancer. So what I tell people is, with no risk factors, you generally don't have to be screened for prostate cancer till you're probably 55 years old. If you don't have any risk factors, we generally recommend starting screening at that point. We talk to you about the pros and cons of screening. But I think for men that have symptoms, that's usually what brings them in. It's not so much that they're getting a check on the prostate. It's either that they have a strong family history of having problems with the prostate, or they're starting to have the symptoms. Well, last year I was not getting up at all. Now I'm getting up once per night. I notice in the morning it's a little harder to start the stream. Like all the things that you would expect and we talked about earlier, those are reasons to come see the urologist. If you have symptoms, it's worthwhile, even if you choose not to do anything about it, but to keep a close eye on it. It's perfectly okay. Coming to the urologist is not a roller coaster. The idea isn't, well, you come to the urologist, you're going to have that roto-rooter. It's not like that at all. In fact, I would say the majority of people I see for this particular problem, we either put on medicine or talk to about behavioral things that might help them with fluids and other things. And then in another group of people that have worsening symptoms and people that aren't relieved, those people we talk to about surgery. But it's not sort of a roller coaster towards surgery when you come to see the urologist.
Okay. I have one more question that appears to be from a man, and then I've got a couple from women.
Okay.
So this last one from a gentleman is, I am in my early 40s and don't take anticoagulants. I had blood in my urine or semen after sex last week. It only happened once. I have no other symptoms. Should I get checked?
Yes. And so the answer to that question is both very simple and then with an exception. Okay. So it's very simple in that if you look at everyone that comes to the doctor with a complaint of blood in the semen, it is almost never, meaning 0.001% or something like that, a pathologic abnormality. Now, the reason why there's an exception, so the answer is it's probably nothing to worry about. The exception is that if you have blood in the urine, that's a little different than blood in the semen. And sometimes it's hard to differentiate, because if you pee after having sex, it could be blood in the semen or blood in the urine. And then the other piece of it is that if you have a strong family history for prostate cancer or something like that, extremely rarely you can see that sort of thing present that way. But it's very uncommon and not something I generally worry about. So most people that come to see me because blood in the semen, since that's kind of a shocking event and something that people come to see the doctor for, I tell them that it's unlikely that we're going to find anything that's abnormal. We might still check their prostate. We might still screen them for prostate cancer, that kind of thing. But most of the time, that's not something that is going to be a big pathologic problem. And there are different ways that you can handle, including abstinence, which isn't really a fun answer, but one thing that you can do to try to help with that. And usually that kind of thing will get better on its own without any additional intervention.
Right. And before we turn over to the ladies, I'd like to put in a plug about our new prostate health HRA, which is on the website. So that can be found in the email too. The link will be there, and men can go and take that prostate health risk assessment.
And I would really encourage you to do that if you're thinking to yourself, I'm having some symptoms, because really what that allows you to do is quantitate those symptoms. Like, am I having a lot of symptoms that really maybe I'm getting up twice a night, and maybe I'm having some trouble in the morning, and maybe I have these three things together that aren't really bothering me that much, but they're symptoms of not emptying your bladder completely, and they're symptoms of prostate enlargement. And that's one of those times when you can have circumstances where the prostate will become enlarged and you'll get bad symptoms, and suddenly the symptoms will get better. And when the symptoms get better, that's either a good thing, and maybe it was swelling or something and it's gone, or it might be a bad thing because your body's sort of getting used to it. Your bladder's sort of stretching out a little bit, and some of the symptoms are equalizing. So, you have to be really careful. So when you do have a change in symptoms, that's a good time to see a urologist.
Great. Okay. So for the women, I am a woman and keep getting UTIs and have to take antibiotics all the time. What else can I do? I wipe front to back, drink a lot of water, even cranberry juice, and still get them maybe every other month. I think this is very common in a lot of women.
Yeah, it's extraordinarily common. And I'm glad we're not forgetting about the ladies in our audience, because it's hard to imagine maybe, but 50% of the patients that we treat in urology are female. Whether that's for kidney stones or infections or blood in the urine or whatever we're seeing them for, 50% of them are female. It's not just the older guys with enlarged prostates. But I think what I would say, the problem with recurrent urinary tract infections, it's a little bit of a cornucopia of problems in that they are incredibly difficult to deal with. And so my heart goes out to the person who's asking this question, because it's a lousy thing to be worried about the next urinary tract infection you're going to have. And often we live in a world where we're trying to do the right things with antibiotics, and often you have to get a culture before you can get antibiotics to treat it, etc. So the person that was asking the question asked a really good question regarding what we should do related, what can I do to stop that? Well, drinking lots of water is a great idea. Cranberry supplements are something that have a little bit of controversy, but most people would agree they probably have a benefit of a sort to helping with that. I think lots and lots and lots of water is probably helpful. I think certainly the wiping front to back is helpful, because again, I don't question the divine design, but everything's pretty close together down there. So you don't necessarily want to get, the stuff from the bowel in the area where the urethra is. And then I also think that one of the things that we didn't mention is there are some probiotics that can help in order to help with the kind of the bacteria that are growing in the rectum and that sort of thing. We have the possibility of having, taking some medicines that can change the composition of the urine. So there's one that changes, that affects the ammonia in the urine and can sometimes reduce your risk of getting infections. There's a lot of things that are out there that have been studied. Supplements, D-mannose is one that comes up. And there's a number of other ones like that you can potentially try. And then finally, one of the problems that exists is many women have problems with recurrent urinary tract infections when they become what we call perimenopausal or postmenopausal. The reason why that is critical is the fact that when the estrogen levels decrease in the body, the area in the vagina changes. And for lack of a better way to put it, it becomes a little bit of a bad neighborhood for bacteria. Bacteria grow there that wouldn't ordinarily grow there, and it doesn't have to do with how clean you are. There's nothing about hygiene that makes a difference with this particular thing. But what happens is, as the wall of the vagina gets a little thinner and as you get some dryness and things like that, that can make a gigantic difference. And so estrogen cream can help enormously. Just topical estrogen cream, which is pretty safe in most circumstances for people, is one thing that works really well and sometimes can be enough to stop that problem. Getting a little further down the road, there can be times when you just have to break the cycle of the infections. And sometimes we'll put people on what we call antibiotic prophylaxis, or a very, very low dose of antibiotic that they take every day for a period of 3 months or something in order to kind of break the cycle of infections. But I do think the other piece of this is, although we don't recommend a complete workup for everybody that has this problem, things like kidney stones can cause you to have urinary tract infections. And so there's a basic workup for people that are getting recurrent infections that we need to take a look at. The other reason that it's super important that we pay attention to this is, the other thing about infections is often people have the symptoms of an infection will call their doctor, they'll call in antibiotics, the symptoms will get some better, but maybe they don't get better completely. And so unfortunately, you can miss things inside the bladder and potentially bad things like bladder cancer if you don't pay attention to people's symptoms. So, and nobody's doing it on purpose, but if you take antibiotic, it gets a little better. You're like, well, it's a little bit better. You know, maybe you don't necessarily go back to the doctor till the symptoms get worse again. And so what I always tell people is you should get your urine checked. You should probably try to have a culture of your urine if you can to prove that an infection is there. And then, you know, go from there in terms of the workup for infection. The other thing to keep in mind, and this is really important, is there is a genetic predisposition, they call it, to urinary tract infections. So some women have receptors inside the lining of the vagina for the bacteria, which seems crazy, but that's absolutely what happens. And so the bacteria can get up into the bladder and then even up into the kidneys more easily in that particular setting. So all those things are things that are important to investigate if you're somebody that has recurrent infections. So, you know, I always tell people, don't live with that. Come to see us because there's lots of things we can do to potentially help other than just looking to make sure the anatomy is normal.
Excellent. Okay. So the last one, and if anybody else has questions, please get them in here quickly. I am a 53-year-old woman who has had a couple of babies and now in menopause. Yes. I sometimes pee when I cough or sneeze. Is it because of menopause or childbirth? Are there any non-surgical treatment options? I've heard about the mesh, but do not want that.
Yes, that is a phenomenal question. And the reason why that's a great question is because it is a very, very, very good, it shows a lot of insight into the problem. So, you know, having babies is something you get what's called pelvic floor relaxation, which means that you get and sort of what we call descent of the pelvic floor. And sometimes that can make the bladder drop. You've heard people that say they have a drop bladder or drop bowel or drop rectum, that kind of thing. That can be one of the things that happens. But the other thing that happens during menopause is what I mentioned earlier, which is that the lining of the vagina becomes thinner. So that tissue in the area of the urethra becomes a little irritated, as well as the tissue inside the vagina. That's called atrophic vaginitis. And it can also thin out the tissue, which makes it so that when you cough and sneeze, there's less resistance there. So there can be a portion of that that's related to menopause. It can be a portion of it that's related to childbirth. And then the other thing is the things you can do to help with that, and it's really, really important. If you remember the Kegel exercises they may have talked to you about when you had the baby is something we tell people about all the time. And that is a minimally invasive treatment where you're really trying to build up that muscle. The problem with exercise is, like most exercise, you have to do it very consistently every day, and you have to do it multiple times a day in order to get that muscle to increase in size. So we talk about you know, doing these Kegel exercises as one thing that can help in those people that are postmenopausal. Estrogen cream replacement to that area definitely will help, you know, to kind of make the tissue a little more bulky. And then finally, there's some other things. There are some injections. You know, mesh isn't the only thing. There are slings that are made out of things other than mesh. So they're, if you will, biologic slings that we can use. I think they're used somewhat less commonly because the mesh we typically think about is the mesh that's used to completely reconstruct the vagina and the bladder wall and things like that, or I should say the floor of the roof of the vagina underneath the bladder. We typically think of that as being the mesh, but there is a small strip of mesh that can be used just to go underneath the neck of the bladder, and that typically has good results and is very safe. The other thing to keep in mind is, you know, we talked about the Kegel exercises and pelvic floor physical therapy. And then finally, there is a procedure where you can inject a material inside that sort of pushes the urethra together. So it makes it more narrow inside and therefore increases the resistance. And that can be super helpful for women that have stress incontinence. So there's some really, really good treatments. And I'm going to put the plug in. We have an excellent, absolutely excellent urogynecology team here at Geisinger. And when you, in both, pretty much in all of our locations, but particularly in the Northeast and here in the Central region, at Geisinger Medical Center, we have great urologic oncologists. And so if you, urogynecologists. So if you come to me and you are having that particular problem, I will usually refer you to them to see and be seen. The other thing that's important is you can have, incontinence is generally divided two ways. or a mixture of two things. One is what we call stress incontinence, and that's what you're describing in your question, which is the cough, sneeze with leakage of urine. And then there's also urge incontinence, which is where you have a strong urge to urinate and aren't making it to the bathroom in time. And sometimes it's a combination of things. So the first thing we do is try to figure out which one of those it is and which is the bigger component. And then there's medicines we can give to calm the bladder and other things as well. So I would say for again, this goes right back to what I said about enlargement of the prostate. For women that are getting older and having trouble with urinary leakage, that may be somewhat normal to have problems as you get older because of the vagaries of aging. But I do think that it's not something you have to live with. There are definitely treatments for most of those things. And really, I would encourage you not to suffer in silence. Come talk to us because we've got lots of options with new ones pretty much arriving every week. So I think there's some great things out there for people with that problem.
Great. Well, that was the last question.
Great. Wonderful. Well, I want to thank everyone for spending some time with us this evening. Please don't hesitate to reach out. I know you're going to get emails and other things, and I think we're planning on giving you planning on providing you with a recording for those of you who may have joined later, caught it later. But I just want to thank everyone, and I would tell you it's summertime here right now, so please stay cool and safe, and enjoy the rest of your evening.